Hi everyone, welcome back to our journal club. Before we get started, I just wanted to update everybody on what is going on. Our website should be up in the next 1 to 2 weeks, so that's exciting. It's going to be awesome. I'm still accepting blog submissions from anybody who is interested in contributing. Whatever topics are on your mind. I think it's going to be really interesting to have everybody's voices as a part of the website. So thanks for that. And the other thing is that I'm working on very actively is our women's conference in September. It's going to be September 26th through the 28th at the Lansdowne Resort and Spa in Leesburg, Virginia. And I have tons of fun, exciting stuff lined up. We've got most of our speakers, although if you are interested in speaking, I still have a couple of slots to fill. But we have attorneys as well as psychiatrists and all kinds of cool topics, so I'm excited to announce all that. And then finally, for those of you that are not aware, I'm trying to get Serena Williams to come to the conference, but working on that really hard because her fees are much higher than I thought. So if anybody has any great ideas for trying to get her onto into our conference, then let us know. So, all right. And hi, everybody. And so let me add Dr. Naveed, who's going to do today's article. Hi.
Hi.
Hi, Dr. Naveed. How are you?
I'm doing good. How are you doing?
Good. Thanks for joining us. I wanted to just introduce Dr. Naveed and thank him for doing tonight's talk. He is coming out of Kansas City. So thank you for that. How's the weather over there tonight?
It's cold, but not as cold as Chicago is.
Oh, okay. Yeah, we were dealing with minus 20 degrees today, and I think minus 40 with the wind chill. So I stayed inside because it was too chilly for me.
Sure, yeah.
Yeah. So I just wanted to read Dr. Naveed's bio. Dr. Sadek Naveed is currently working as assistant professor of psychiatry at the University of Kansas Medical Center. He obtained his medical degree from Nishtar Medical College, Multan. Dr. Naveed completed adult psychiatry residency from Griffin Memorial Hospital, Oklahoma, in Child and Adolescent Psychiatry Fellowship from the University of Kansas Medical Center. He's currently the president of the American Academy of Child and Adolescent Psychiatry, Greater Kansas City chapter. So thank you for joining us. And of course, now it makes sense why you chose this topic. So thanks for picking up this article, and go ahead and take it away.
Sure. So first, the title of the article is Inflammatory Markers and Chronic Exposure to Fluoxetine, Divalprox, and Placebo in Intermittent Explosive Disorder. I think the word chronic can be misleading. The whole duration of study was about 14 weeks from screening to the end of the study. This study was conducted by Enrico Caro, Royce Lee, Elizabeth C. Breen, Michael R. Irwin, and they were from University of Chicago, UCLA, from 2 campuses of UCLA. So let me tell you a little bit about the background and intro of this article. So this article basically looks at the relationship between inflammatory markers and aggression and different psychiatric symptoms. So they have found a positive relationship between acute phase reactants like CRP, C-reactive protein, and IL-6, and positive relationship between these acute phase reactants and anger, hostility, and aggression in community samples, in patients with personality disorders, and patients with intermittent explosive disorder. In some of the lab studies or in some of the other studies, they found that when they injected or applied interleukin IL-1B and IL-2 to periaqueductal gray matter and hypothalamus, there was an increase in defensive aggressive behaviors in cats. And similarly, in clinical studies, when patients were treated with pro-inflammatory anti-inflammatory agents, there was an increase in aggressive behavior. So idea behind that was that behind this study was that if there is an increase in aggressive behaviors with inflammatory site mediators, then if we treat them with anti-aggressive agents or any kind of treatment, there should be a reduction in inflammatory markers. They reference a study about depression where they treated these patients with antidepressants and CBT, and there was a reduction in the level of IL-6, interleukin 6. So they conducted this study. The number of participants were 30. It's a 12-week double-blind placebo-controlled trial. So their hypothesis was that if they treat these patients with fluoxetine, divalprox, there should be a reduction in the levels of IL-6 and CRP. And this reduction should correlate with the degree of improvement in their aggression scores. So that's two things they looked at. And as far as, these inflammatory cytokines are concerned, they also looked at some other mediators like interleukin 1 beta, interleukin 2, 8, and TNF alpha. And in addition to that, they look at an anti-inflammatory cytokine, which is IL-10. So if you look at the case 2, if you guys have articles in front of you, so the first phase was screening phase. And I think this is important to know about the design of the study, because they talk about a little bit about that in discussion 2. So they went to screening process, and in screening process, they looked at the inclusion criteria, which was, they should have a score of more than 15 on overt aggression scale modified. And I will talk a little bit about scales and what outcome measures they used. So they should have a score of more than 15. Then they, screen these participants. Then they randomize them into 3 groups. So one group was placebo, and then fluoxetine, and then divalprox. So they included all those participants, and they in this study they did inflammatory mediators. They looked at their levels before the start of the study and then at the end of the study. So they, in their final analysis, they included the participants who were able to complete the trial, and as well as they were able to provide samples for both pre and post markers at the end of the study. For rest of them, they talk a little bit about them, but they did not include that in final analysis. So in methods parts, as far as subject is concerned, that's what it talks about. So there were about 42 patients who did not complete trial, about 18 patients who out of 42 out of 90, and about 18 patients who were missing one sample after the study. And then they talk about how scores were different in both groups. But I had a question here where when they talk about the both groups, if you look at table number 2, word aggressive scale modified for aggression score, the score was pretty high for fluoxetine. So it was 101 for fluoxetine, and for placebo group it was 69, and for divalprox it was 50.9. So I don't know whether it was statistically significant difference. So that's what they meant by that. Anyway, so they excluded patients who were struggling with mania, hypomania, schizophrenia, delusional disorder, or with a current major depressive episode, or patients who were currently dependent on alcohol. Now, the next part, they talk about diagnostic and medical evaluation. So I will talk about medical first because it's pretty simple. So they did certain physical examination. They did lab work just to make sure that these patients were not struggling with any physical health illnesses. As far as diagnosis is concerned, so I think they had a pretty good stringent process. So there were research psychologists involved who did structured interviews in the form of structured clinical interview, diagnosis, and then structured clinical interview for personality disorders. And then A clinical interview was done by a psychiatrist. They also looked at the review of data, and then they diagnosed them based on a best estimate consensus process. So table 2 talks about current syndromal disorders and lifetime history of syndromal disorders, and then personality disorders. So if you look at it, patients with any depressive disorder among lifetime syndromal disorders, depressive disorder were the percentage of people who were struggling with depressive disorders was pretty high. As far as assessment of the scale is concerned, so they did their primary outcome measure was overt aggressive scale modified, which is commonly used instrument in research studies which focus on aggression. So they looked at two scores, aggression scores and irritability scores. It does talk about that overt aggressive scale modified irritability scores was used as a clinical indicator of the or indicator of a global assessment of patients' impulsive behaviors or impulsive aggression. In addition to that, they also look at a scale called lifetime history of impulsive aggression over the past weeks, then life history of impulsive aggression. And other scales were the Sperry Aggression Questionnaire, Life History, Impulsive Behavior, Broad Impulsiveness Scale, and Beck Depression Inventory. But their main scale was Overt Aggressive Scale Modified. So what they did as far as the dosing is concerned, so there was these patients did not use any kind of medications 4 weeks prior to start the process of the study, which will be screening. And then after the screening and everything, there was 2 weeks placebo. Basically, they in those 2 weeks they just gave them placebo and nothing else. And then they randomized these patients into 3 groups. So one group with placebo, second with double prox, and third one with fluoxetine. In fluoxetine, they started with 20 milligram. They increased the dose to 40 and then 60, depending on 25% improvement from last time points. For Depakote, they started with 250 milligram twice a day, went up to 500 twice a day, then to 750 twice a day, and the maximum dose was 2,500 milligram. And then next, it talks about inflammatory markers, which is mostly it describes lab process and what happened, but I don't think we need to know about that. It's mostly lab work. And one thing which we should know is that they did one sample at the pre-treatment and placebo lead-in phase. You remember after screening, there was a 2-week placebo lead-in phase. And then at the end of the study, which will be about 14 weeks from that point. As far as results are concerned, so as I talked previously or mentioned previously, that there were total 90 participants, but only 30 actually did all the steps. So for analysis purposes, they only included those 30 in the final analysis. It does talk about there was no differences and all groups were similar. As far as anti-aggression outcome measure they did say that if fluoxetine and divalprox and placebo work, there should be an increase in improvement in anti-aggression outcome. So they did not, and we remember that they did a weekly overt aggressive scale modified for aggression scores and irritability scores, but they did not notice any improvement in any of the groups. But what when they did the secondary analysis, which went back and they kind of did an analysis on all 90 subjects, regardless of whether they did they complete the trial, completed the trial, or they did all both lab work at the start and at the end of the study. So they took all those 90 participants, and what they observed that there was a decrease in overt aggressive scale modified for aggression. It does talk about a little bit about mean log score. So it was based on statistical analysis. The scores were not distributed evenly, like those 2 and 3 standard standard deviation, so they changed it to mean log. I think it's a statistical concept. Anyways, so they did and observe a change in overt aggressive skill modified for aggression, but they did not observe an improvement when they joined all those three groups. They did not see an improvement in overt aggressive scale for irritability. And we do remember that overt aggressive scale for irritability gives us an estimate of patients, or global estimate of patients, irritability or functioning in last 1 week or so. As far as plasma inflammatory markers are concerned, they did not notice any change in those levels before, and there was no difference between before and after the study. There were about 21 out of 30 subjects which had elevated level of inflammatory markers before the study, and then 9 had normal levels, but there was no change in their levels before and after the study. Now, in discussion, and it does cause talk about intra-class correlation among plasma inflammatory markers, and so it says intra-class correlation among each of inflammatory markers were high over a period of 14 weeks. As far as discussion is concerned, so as we talked about, that there was no improvement in aggression scores, which was one outcome measure, and there was no change in their level of inflammatory markers. So, and they say that, what can be the possible reason? So, one of the reason was that they had only 30 subjects in the study, 30 participants in the study, so that can be one reason that didn't see any change. But it also says that even when they did the secondary analysis and they included all those 90 subjects and they looked at their scores, in overt aggressive scale modified irritability scores, there was no change. The second thing, which they think is the most likely reason for failure of this study, that and it cites some of Dr. Cooker's some of the previous studies. They said that at that time they considered. So remember, I talked about inclusion criteria being overt aggressive skill modified should have score of more than 15. So in this study, they did that score level as that they scored them at screening phase, but in the previous studies they did at randomization phase. So I think some of these patients may not be as aggressive at the time of randomization or when actually studies started. So they feel like that there was not a stringent criteria, and we see that this in our and that's just my assumption, that we see that patients who are mild to moderate depression, they're more likely going to have placebo response with antidepressants. So I think that's what they are trying to say. Third reason they are trying to tell is the difference between state and trait. And here they talk about some of these patients who have an improvement in acute phase reactance, and they quote certain studies with Zoloft and some other antidepressant state when patients were acutely depressed, and there was an improvement in their depression scores. Then at the end of this article, they talk about limitations. One thing they said that which could have been done is the sample size could have been larger, and and the estimated sample size was about 500. So conclusion was that that there was no change in inflammatory markers with use of these medications. And they said that a hypothesis will need a medication-free subjects with intermittent explosive disorder after a sustained period of. So they said that after medication-free remission of impulsive aggressive behavior, so you need to have a little bit more studies. Now, I'm happy to take any questions.
I'm not sure if we have any questions so far, but people can always post afterwards, and we'll try to get to those. So what would be your take-home points from having gone through this article?
So my take-home message was, so I think and there are a lot of studies which are coming out. There's some with, suicide where they see an increase in acute phase reactants, and, some of the biomarkers also talk about, these, stress levels like cortisol and all of those things. So I think what they were trying to prove was that there was an increase in biomarkers, but even with the treatment, it did not work. But I think one of the reason in which they also list in article is that it did not work because patient might not be as severe. They did not have as much severity compared to some of their previous studies where they did see a change in the biomarker level. So I think they may need to go back and look at the design of the study and criteria, and then redo the study with bigger sample size.
Okay. And would you say that there's anything that we can take out of this, like to apply to clinical practice, or is this more still in the research phase?
I think it's still in the research phase.
Okay.
They may ask a question, in the actual exam, but I felt like I'm not going to change anything in my practice based on just reading this article.
Okay. Well, thank you for going through that summary. Sure. I think this was one of the harder articles to go through. So thank you. We have a Vaid. I don't know if I'm pronouncing that correctly as well. I don't know if you know her or not, but she thought you did a great job too. So, all right. So we will wrap up. Next week we have. We are changing gears and going to switch topics, and we have Dr. Max Lichtenstein, who will be presenting actually both Monday and Wednesday at 7:30. So stay tuned for that. If you're not on the mailing list and want to join, just email me directly at psychiatrynetwork@gmail.com and just put listserv in the subject title, and I'll add you to it. So thanks, guys, for watching, and thank you again to Dr. Naveed, and have a good night, everybody.
Good night. Stay warm.
Okay, you too. Bye.